its memo was not good because of that location. That location was not very good to take memo, so I took another one. This one.
Okay, fine. So you'll do mammography as the first imaging, right?
Yes, ma'am.
So any difference between what you do in less than 40 years and more than 40 years of age?
So in less than 40 years, generally the young age patients have dense breast, so we prefer ultrasonography. And
yes.
After 40 years, we generally prefer this sonomammography or mammography.
So what all are the things that you look for in ultrasound of the breast?
So ultrasound of the breast, first of all, it will tell us about the exact size, location, and then it's taller than wider, vascularity, and
so describe. Suppose it's your lump, that one lump which is seen on mammogram only. So describe it on ultrasound.
So it can be an around 3 into 2 centimeter mass in the right outer breast. And
no, I'm asking in ultrasound. Describe in ultrasound.
Okay. In ultrasound, hypoechoic breast lesion in the right breast in whatever quadrant, which is right, like I'm saying.
Tell whatever it is, their quadrant in whatever clinical examination you told, no? Same thing you told.
Okay, ma'am. So in upper inner quadrant, according to that last case I presented. So that was at 10 o'clock. So I'm saying like that. Upper inner quadrant, hypoechoic lesion in the left breast around 4 into 3. Actually, I'm not remembering the exact size, ma'am, now.
No problem. You just tell it. I want to know what all you want to see in ultrasound. How do you describe a lump? That's what I want to know.
Okay, ma'am. And with like it is homogeneous or heterogeneous, and increased vascularity or not, or any cystic lesion or necrosis is there or not, like that we will see.
And the most important thing you didn't tell.
Microcalcification.
Microcalcifications, vascularity.
No, that you don't see in ultrasound.
Axillary lymph nodes.
Nodes, yes, ma'am.
Nodes, correct?
Yeah.
And,
yes.
And something else. Something characterizes the lesion, no? So based on that only you will take decision on what to do.
BI-RADS.
BI-RADS staging,
yes.
Very important, no?
Yes, ma'am.
Yeah. Now you tell me what is BI-RADS?
So
what is BI-RADS?
BI-RADS is breast imaging and reporting data system. So it characterizes the breast lesion into 7 categories, 0 to 6, and 0 being like indefinite, indeterminate, like we need some extra imaging or we have to correlate with some previous imaging to make a final call. And 0 is normal, 1 will be benign, 2 will be probably benign, 3 will be suspicious. 1 will be normal, 2 will be benign, 3 is probably benign, 4 is suspicious, 5 is highly suspicious, and 6 is malignant, already proven.
So what is the incidence of malignancy from in all these subcategories?
So from like up to class.
What do you do for BI-RADS? What do you do for BI-RADS 1? What do you do for BI-RADS 2? What do you do for 3, 4? 4 again is divided into 4A, 4B, 4C. Right?
Yes, ma'am.
Oh.
So BI-RADS 1 as it is normal finding, so we will do the routine follow-up. And BI-RADS 2, because of it is benign, if we need like any confirmation, then we can do sono-guided biopsy, or else we can follow annually. Then
BI-RADS 2 is what?
BI-RADS 2 is benign.
Then it is follow.
Yes, ma'am. Yes.
Then BI-RADS 3?
3, it has risk of malignancy less than 2%. So we will call like close.
It is probably benign, right?
Yeah, it is probably benign. 6 monthly.
So what do you do in that?
6 monthly follow. Yes.
Yeah, follow. So from starting from 4, you will do intervention, right?
Yes. Right. Yes.
Yeah. So what is the incidence of malignancy in 4A, 4B, 4C?
In 4 as a category ranges between 2 to 95%, ma'am. And exactly I'm not remembering for A, B, C, but I think 4 is 4A
Yeah,
is
somebody can help him.
50. Yeah.
10%, 10 to 95, more than 95.
No, more
2
than
to 10,
No.
10 to
No,
50,
no.
50 to 90.
Correct.
Yes.
He's correct. So 2 to 10, 10 to 50, 50 to 95. And more than 95% is the other one. Okay.
Yes. Yes.
And 6 is biopsy proven, right? So
60.
why was this BIRATS proposed?
Why was BIRATS, ma'am?
Why was BIRATS proposed?
For making a standard reporting system for reporting of breast lesions overall.
Yeah. It's standardized the language of for reading and reporting. Okay.
Yes.
So now, so how do you see a metastatic lymph node on an ultrasound?
On ultrasound, it will be taller than wider, thick cortex.
Lymph node.
Okay.
Not the lesion.
So first it will be like.
So why is it taller than wider?
Generally, nodes are round when they are.
No. Taller than wider is the lesion, not the node. Okay. Why is it taller than wider? Is it related to
elasticity of the lesion is lost? So that's why when the probe is kept, it seems more taller.
So it is compressibility, that is of the lesion. Elasticity also, that is one way of expressing it. So the malignant the lesion is, less elastic there or less compressible there. So they'll look taller than wider. Whereas benign, they're more compressible. So they'll look wider than taller. Yeah.
Okay.
So what is the probe of ultrasound you use?
For breast. Then
High frequency ultrasound.
5 megahertz, 5 to 10.
What is that high frequency?
7.2 to 12.
7.5 is.
So 7.5 is high or 12 is high?
12 is high. Routine is 5 to 7.5, I think, and more than 10 is high.
Yeah. Generally, 2 types of probes only will be there, 7.5, 12. So here you use high frequency ultrasound. Okay.
Yes.
So then how do you describe a lymph node?
So lymph node, first we will give the size, then the cortex thickness, thickened cortex, loss of fatty hilum, vascularity, and it's like heterogeneous, homogeneous, or is there?
So go in an order so that you will not miss. First is what?
First side, shape. Yes.
Hypoechoic.
So shape क्या होता है?
Shape will be round in malignant.
So size generally it is taken more than 1 centimeter, but it can still be less than sub-centimetric. Also can have significant findings that they'll be metastatic. Okay.
Yes.
Then what about other characters? Size, shape over. Next, you told something about thickening.
Thickening of cortex.
Then from cortex you go inside.
Loss of fatty hilum. Then texture like heterogeneous, homogeneous, and necrosis.
Increase vascularity.
Increased vascularity. So these are all the things you see on this one. So what are the things? What are types of mammogram? I mean views.
Screening and diagnostic.
So,
yes.
Types of mammogram are?
Screening and diagnostic mammography.
What is screening mammogram?
Screening has 2 views, MLO and craniocaudal, and it is used for screening the normal population or opportunistic screening. Like in the developing countries, we do opportunistic screening.
It has only 2 views. Okay, so
yes.
that is. So what is diagnostic mammogram?
In diagnostic mammogram, we use some additional view for the diagnosis of lesion as well as seeing any other microcalcification present or not. Or that view can be like spot compression, magnification, lateral target or bullseye, valley view, like that.
Okay. So what is tomosynthesis then?
Tomosynthesis in mammography, we like X-rays are projected from a fixed angle. In tomosynthesis, the rotating arc projects the X-rays at various angles. So it projects the 2D thing in a 3D view. So we can better localize the lesion.
So we can get thin slices of it.
Yes.
Okay.
Yes.
So very thin slices so that the smallest of the lesions are picked up. Okay.
Yes. Sir.
There's also 4D mammogram. Okay. So
Okay.
then what is the things you see? Okay. You tell me the views.
View is mediolateral oblique view, craniocaudal view, and
Okay. So where do you place the film and where are the rays coming from in mediolateral oblique?
in mediolateral we will project the rays from medial to lateral, and the film will be formed at the lateral side.
It will
Placed,
be 45
Are you
degree. 45
Are you
degree.
sure?
Yes, ma'am.
Okay. Craniocaudal के कैसे project करते हैं?
Cranial to caudal, upper to like upper, from the upper end source will be there. The radiations will be exposed, and at the lower end the films will be taken.
Films
Caudal.
will be placed below the
Breast.
patient surface. Yeah. So how do you read a mammogram? So tell me all the points, like what all you want to read in a mammogram.
So first we will tell we will tell about the view, what view is there, and then
First you will tell this is
adequately.
a mammogram of a patient aged about so and so. Okay. Then you will tell about the view, right?
Yes. Yes, ma'am.
So first patient details are important. Okay.
And
Then
indication as well, ma'am, like it is screening or diagnostic, like that.
yes.
Then we will tell whether it is adequately taken or not, and the exposure.
Okay. Then
And after that, if it is adequately,
go from outside to inside.
yes, ma'am.
Tell me all the things from outside to inside.
So this is a mammogram of 71-year-old lady, and done for diagnostic mammogram and for diagnosis, and it is as the left inframammary border is not seen, so it is not
And
adequately
ACR
taken.
grading we have to mention.
And yeah,
Yes. You have to
And
mention
ACR.
ACR grade.
So it
Tell
is
me ACR grading.
so there are 4 grades, ma'am. A, B, C, D. And A grade is entirely fatty breast. B is scattered density. C is heterodense, and D is extremely dense. And
There is some percentage, right?
yes, ma'am. 0 to 25, 25 to 50, 50 to 75, and more than 75. But
Okay. So you are happy with the fatty breast, or you are happy with the dense this one glandular breast?
so depends upon like what surgery we are planning. If we are planning BCS,
No. I am just asking to pick up the findings on a mammogram.
that is better, ma'am. That is because dense will make the picking of lesion or microcalcifications picking will be difficult in dense breast.
Okay.
Yes, ma'am.
Yeah. What is the exposure amount of exposure through a mammogram?
It is
So it's through
0.4 millisievert, ma'am, or 0.04 centigrade.
0.1 it is.
0.1 millisievert for X-ray, I think.
Sievert नहीं, centigrade is 0.1.
Centigrade है 0.1. Okay. 0.1 centigrade. Okay. It is equivalent to how many X-rays?
4 X-rays.
4 X-rays.
Yeah. So, is there any chance of radiation exposure and getting any radiation-induced cancers through mammogram?
I think no, ma'am. Like no. In
In
screening, no.
100 out in 100 में 1 is the chance, no?
10,000 में एक.
1000 it is 1. Okay.
Okay.
So not in 100. 100 man में significant है. Oh. So very less, not proven evidently on studies. Okay. So there is some amount of risk, but multiple mammograms in a year, then only, I mean, in her lifetime, then she might develop some risk. Okay. So, yeah. So then what is, you were telling me about ACR grading over. Next, what do you see?
After ACR grading, we will start describing lesion either from outside in or inside out. So I will tell from outside. So the breast architecture is normal bilaterally, and the skin thickening is normal. Nipple profile is visible well. Then ACR grade is A, and there is dense, highly dense lesion with speculation seen in the right upper outer quadrant, and
so with one view you cannot tell. Okay, upper outer. So
yes.
You have to project both the views.
Yes.
So how do you tell it's upper outer? Tell for the benefit of others.
So in MLO view, above the nipple, line above the nipple, it will be upper. Below it will be the lower. In the MLO view, craniocaudal view, the same. Above the nipple will be outer, and the below the nipple will be inner quadrant. So based on both these, we will. It is upper outer.
Okay. Fine. So describe the lesion. What do you call it?
It is a highly dense lesion with speculations all around.
But highly dense or some word?
Hyperdense only.
Hyperdense. Hyperdense.
Yeah, hyperdense.
Lesion. Size, and then size we should comment like I can 2 into 2 centimeters lesion with speculations all around. And muscle not involving the underlying muscles, and that's all I can comment. There is no
architectural distortion with speculated margins. Okay, heterogeneously dense lesion. Okay, so and single solitary lesion with no evidence of any microcalcifications or no evidence of any other lesions. Okay.
Yes.
No
architectural distortion. How do we say? I mean, how do we say that?
See, uniformly. If you have seen a fibroadenoma, so how it will be uniform. Okay, it will not be the speculated margins and all those are components of this architectural distortion. Okay,
we are talking about parenchyma of the breast.
Breast parenchyma in relation to lesion.
Okay.
Okay, when lesion is present, which is suspicious, there will be architectural distortion. Okay.
Ma'am, so one more question, ma'am. Based on mammogram, how do we classify these bireds of the lesion? Suppose this is speculated, we can say it is something around 4CR5. But if it is not speculated, well-defined, round, lobulated, hyperdense lesion.
Every category has its features, like how they appear.
Every category will be having points again. So the asymmetry, the mass lesion, the nature of the lesion. Okay. So it's enhancement. Each has its point. Okay.
Okay.
So So then what else?
Then we will see is there any axillary lymph node visible or not. So in this.
To the extent visible. So is it the pectoral? You can see the muscle.
Yes. This.
You can see the inframammary crease.
In right
to
side.
To some extent.
Yes, but
to
left
some
side.
Extent.
Yes,
yeah,
yes.
To some extent it's okay.
Yes, yes.
Not very bad mammogram as such. So all this you see. So how many lesions are missed on a mammogram? How many percentage of lesions are missed on a mammogram?
10 to 15%.
I think it is 10%, but let me check, okay? I remember it as 10%.
I also, but for sake of range, I told like 10.
Yeah, I remember it's 5 to 10, but I may be wrong. I don't remember exactly. Okay, I'll just check it. Huh?
Okay.
So then, yeah. So not very good for lymph nodes. Okay, mammogram better. Ultrasound is better for lymph node characterization. Okay.
Yes.
So okay. Any other imaging you want to do?
For staging workup, we will do the if the lesion is locally advanced, we will go for whole body.
Let me ask you. Sorry, in mammogram only, what are microcalcifications?
Microcalcifications are having less than 0.5 mm lesions, which are having some particular pattern like linear branching, amorphous, like that.
Can you tell me some examples where it is tram track?
I think
where it is popcorn, where it is tram track.
Fibroadenoma is popcorn. And tram track, I think ductectasia and traumatic.
With age, vascularity, the vessels will get thrombosed. There also you can get. Okay. Then?
And pleomorphic calcification is one of the risk factors.
Can you tell me typical description of a malignant? How do you describe calcifications in a malignant lesion?
So there will be microcalcifications, linear branching, amorphous, pleomorphic,
punctate.
Punctate, I'm not sure of.
What is clustered?
Clustered, yes, ma'am. Clustered, like
clustered, pleomorphic. Then
pleomorphic and microcalcification will be at the end, and what is left? Linear branching or amorphous pattern, and then microcalcification.
Yeah. Okay. Fine. Then yeah, calcification is that. Then next, we leave anything in mammogram? I think we discussed. Okay. So what about next imaging? What do you want to do? Ultrasound and mammogram are done. What is the stage of your clinical staging of your lesion?
Clinical T4A and T4, it was skin B, T4B, N0, MX.
T4B. So it's not an early lesion, right?
Yes, ma'am.
So would you like to do any other investigations?
For staging, I will like to do, ma'am, already 18 FDG PET scan.
By PET?
Because PET is...
I do agree. Okay, you can do PET. But substantiate your answer with a proper...
So PET will be a single stop solution, ma'am. It will tell us about the bony lesions as well and distant metastasis, as well as it is good for detecting nodal and distant metastasis.
Okay, so what does PET miss?
Brain lesions, brain.
Liver
lesions.
Yes. Yes.
And liver, it can also miss liver.
Brain, liver.
Salivary glands.
Nah.
Bone marrow.
PET is good for bone.
Yeah.
Mainly brain lesions. Okay. Liver, better on MRI. And so, okay, I'll ask you one basic question about PET. Okay. So, are the poorly differentiated lesions better picked up or well differentiated lesions better picked up on PET?
Well differentiated, I think.
Poorly differentiated better pickup.
Yeah, poorly differentiated are better picked up. Okay.
Because they have
So-
high proliferation rate and
Yeah.
well
So
differentiated.
what is PET based on, Rakesh?
PET like uptake
What
of,
is the principle of PET imaging?
it is based on like uptake of glucose, like that Warburg effect. Based on that, the cancerous cells will uptake more glucose.
F18.
Sorry?
FDG uptake is more in rapidly dividing cells.
Yes.
Okay. So now you can understand why Soumita told poorly differentiated.
I thought
Ma'am, for example, you said poorly differentiated in CS stomach. Poorly differentiated and signet ring variety do not do well on PET.
No. See, segment ring is different. Okay, mucinous compound is not picked up by PET. Okay, that is different entity. But generally, PET picks up poorly differentiated. Why poorly differentiated? Because they are rapidly dividing and they become undifferentiated at one stage. Okay, so that is better picked up by PET. Well differentiated, their rate of division is low. So whenever the rate of division is low, this F18 uptake is also low. Okay, so especially this question comes in when you do a GIST. Okay.
Or ma'am, neuroendocrine tumor also.
Neuroendocrine, gastrointestinal stromal tumors. For that, you need to know when to do PET. Okay. When it is poorly differentiated, they pick up well. When it is well differentiated, they don't. Okay. So
Ma'am,
PET is
is
not
there a
good modality.
differential pick up on the lobular or one also? Are lobular also poorly picked up?
Yeah. So whenever there is some mucinous component, okay. So the lobular lobular cancer is good cancer or bad cancer compared to ductal?
Lobular is bad, ma'am. Spread is like it can involve the whole breast like that.
Is it?
Without being detected.
Which has worse prognosis in breast cancer?
Inflammatory breast
First
cancer.
is inflammatory, then IDC. Our IDC is no specific.
Yeah, inflammatory is different entity, but in pathological variants, which has the worst prognosis?
No specific type, IDC, no NST.
Most common cancer is the worst.
Yeah, lobular presents in both breasts and all, but it has good prognosis compared to IDC. Okay. So IDC has worse prognosis and it's the most commonest cancer. Okay. Other varieties like mucinous, papillary, tubular, everything has good prognosis. Okay. So medullary is no longer classified as separate variant. Okay.
Yes.
So I think last time we discussed all this, right?
Yeah, we discussed it.
Yeah. So
ma'am, on this point, for this point, same point for NET, because neuroendocrine tumor only type 3 only we can do PET scan. Otherwise, for moderately and well differentiated, DOTA-TET is indicated. If DOTA-TET is not available, then we can do PET scan. And this is the reason ki it is highly proliferating and Ki67 is more than 20%. That's why we are doing.
Correct. You're correct. So, what is the indication for excision biopsy of a lesion, Rakesh? What are the exceptions?
Excision biopsy, ma'am, if on core, like it is atypical hyperplasia or flat epithelial with atypia or LCIS.
Atypical ductal hyperplasia. Okay, one.
And papillary lesions, LCIS.
Yes.
And radial scar or sclerosing.
Radial scar third. Then?
Pleomorphic LCIS.
Discordance with clinical and imaging, clinical and medical.
5 are over.
Yes, sir.
I think there are
this much only, ma'am. 4 are there in DaVita table.
More are
I
there.
think there are 6. Okay, if I'm not mistaken. Radial scar, discordance, histopathological discordance, then this one, pleomorphic LCIS, Then atypical ductal hyperplasia. Then papillary
lesion in LCIS.
And failure to sample microcalcifications.
Failure to sample microcalcifications. That is one more. 6 are there. I remember. Yes. That's fine. Okay. This is favorite question of old examiners. Okay. Whenever some external examiner is old, no, they will ask this question. Okay. So next, So coming back to, do you want to do CT? Okay, you told PET CT.
Yes.
Fine. So what is PET CT? I mean, when do you say the lesion is like PET suspicious or something? What is the measurement what is the measuring unit in which they express that significance?
That SUV uptake.
When is it significant?
More than 2.5.
Yeah. 2.5. Then 2.5. Okay. More than 2.5. But sometimes the inflammatory lesions also can cause increase in SUV. Okay. It has to be correlated clinically.
Yes.
Fine. So anything? Yeah. So
Madam, I just wanted to ask, like, what should be our indication for, like, this is a T4B lesion, that is fine. But suppose from which T stage or T and N stage onwards, will it be justified to say for staging when will you use CT scan? Because if you go by the NCCN, they have just given they've just written high clinical stage. Use CT scan. High clinical stage.
It is locally advanced lesion in which you go for imaging. For early breast cancer, no imaging is required. Only your clinical examination. Okay. So
T3N0 or T2N1 onwards, can we say that, madam? Then if there is
node positivity. Node positivity. T3N. What is locally advanced?
Ma'am, actually this question was discussed in our NB class. The examiner was like the same we told na. So they said ki since you are sending all patients for NACT, HER2 positive and TNBC in spite of size more than 2 centimeter, then for reassessment
for
after
comparison,
treatment,
you can do a PET.
Yeah.
See, what does NCCN give? PET can be considered. Okay. PET can be considered. Not everywhere PET is available, right? So you can do individual. If you tell individual investigations also, you are not wrong. That's why I told I don't disagree if you tell PET. It is recommended. Okay. So it can be considered is what the word they use. Okay. It can be considered, but you can do individual investigations in case PET is not available. But PET is a good modality for comparison for future, to assess the response. Okay.
For TNBC and HER2 positive, madam, for TNBC and HER2 positive, should we, before sending for neoadjuvant chemotherapy for more than 2 centimeter lesion, we should assess for distant mets for all TNBC and HER2 positive?
In early cases?
Because we are sending more than 2
centimeters, yes. If you are sending for NACT, TNBC and HER2, you send for NACT. It's ideal to send for NACT. So whenever you want to do response assessment, you can consider for PET. Okay, because they have high rate of distant metastasis compared to hormone receptor positive lesions. Okay, the only area where you don't tell, I don't prefer doing any investigations is less than 2 centimeters, hormone positive or early stage lesions. Okay, rest all TNBC or HER2 where you are sending for NACT, it is better to clarify that it is locoregional disease rather than a distant metastasis. Okay, before giving NACT. Okay, so yes, even if you don't do, your medical oncologist colleague will do. Okay, so you are not wrong in saying that in TNBC and HER2, before sending prior to NACT, I will do a PET CT. It will also be helpful for my future response assessment. Okay, you're correct. No issues. If you tell like that, then they will agree. Okay, so a metastatic workup has to be done. Either it is a PET or it is individual CECT, abdomen and pelvis with thorax and all these things. Okay. So bone scan. When do you do bone scan? And what is the radioisotope used in bone scan?
Bone scan, like if we do PET, mostly we can detect the bone lesions. But if we are just
forget about PET. PET we have discussed. Now you tell me bone scan.
Bone scan, if the patient is symptomatic or alkaline phosphatase is raised.
Okay. So what is the radioisotope used?
Technetium 99.
Technetium 99 only.
Technetium 99. What is the other, not very commonly used, but what can be used for a bone scan?
Fluorine based.
Sodium chloride.
What?
Sodium, fluorine based sodium.
Yeah, it can be done. Okay, so yeah, in bone scan is individual investigation. Then what do you do for thorax? What do you do for abdomen? NCCN recommendations.
Thorax, abdomen, like in locally advanced case, our PET CT will cover, or else we can do CCT, thorax, abdomen as well.
No. If you're not doing a PET CT, Rakesh, individual investigation.
CCT, thorax, abdomen, pelvis, we will do.
Do you want to do contrast for thorax also?
Like thorax, because there can be nodes, especially internal memory.
Is it mandatory to do? Don't you pick up it in plain or HRCT thorax? Is contrast mandatory?
Parenchymal lesions we can detect on HRCT or non-contrast, but mediastinal nodes contrast will be better because we are endemic, like for tuberculosis and many infective conditions. For better characterization of mediastinal nodes, if any node is enlarged, contrast.
Ma'am, we have to do workup in the same sitting. So while writing two different investigation, non-contrast thorax and CCT for abdomen, it won't be like. So for
mediastinal, contrast is better.
Exposure is more, no, Soumita. So if you give a contrast for the doing three things, okay. So exposure is more. So abdomen pelvis, generally what they say is you can do a CCT abdomen pelvis with a plain or HRCT thorax. Okay. So that will suffice.
They have to do lie down patient two times, or both can be done in the same sitting.
No, how do you do CCT? You tell me. Don't you take a plane before?
Yes, at first go we can take plane, then we.
No, you will take a plane. Then you'll give contrast and then take pictures. Okay.
But for nodes, ma'am, like if they ask for nodes, like mediastinal nodes can be there in CA breast.
See, everything like the HRCT will pick up. Okay.
Okay.
It's not plain CT, but high resolution CT will pick up even nodes. Okay.
Okay.
So, yeah, what is the most common site of metastasis based on hormone receptor positive TNBC or HER2?
So HR positive will go to bone mets, and HER2 will go to viscerage. TNBC brain.
HER2 will go to?
Visceral, like more common visceral mets in HER2. And TNBC brain.
Which is more common in brain, with TNBC or HER2?
TNBC, I think. TNBC.
It's HER2.
Okay.
HER2 is more common. TNBC is spreads to other viscera. Okay.
Okay.
More common. Okay. It can go to brain, but HER2 is more common to go to brain. Okay. Okay. Then we discussed about this metastasis. Okay. So what kind of bone mets are present?
Like osteolytic, and sometimes can be sclerotic as well.
What are more common? Yeah, mixed can be present in breast, but I do agree. What are more common?
More common osteolytic.
Blastic.
Okay.
Yes, ma'am.
Blastic is in prostate. Okay. Osteolytic is more common in breast. Okay. Then, right, that is about metastasis. Okay. Can you tell me leptomeningeal metastasis, something spread through CSF, which cancers have more of that kind of spread?
Like molecular type, ma'am.
Leptomeningeal metastasis किस subtype में common है?
Leptomeningeal.
Your options are HER2 and TNBC. It's obviously not hormone receptor positive. So, in
HER2 is more prone to brain mets, so I'll go for HER2.
Spinal, leptomeningeal metastasis, CSF fluid, which is more common?
HER2.
TNBCs. Okay, fluid through fluid. Okay. TNBCs are more common. Okay. Then what about another thing? Yeah. So now LCIS is not there. Okay. But one variant of LCIS was considered a different entity. It behaves differently from the other like subtype.
Pleomorphic.
Pleomorphic LCIS.
Yeah. What is why is it different?
It behaves like DCIS.
It can be picked as pleomorphic calcification, so it can be confused with DCIS. It's microcalcification. It has microcalcification and can be confused with DCIS. And also risk factor for malignancy conversion into
anything related to E-cadherin
loss. So based on your question, ma'am, as LCI generally don't have E-cadherin, this might have E-cadherin.
Yeah. So anything, yeah. So that's about metastasis. Bone we discussed.
LCIS as a term has been removed, or it has been removed from the.
It has been removed. It has been removed. That's why I asked previously. Okay, it has been removed. Okay.
So it is
now
removed as a term.
lobular carcinoma is there, but no LCIS. Okay, it is no longer considered because to give it a separate entity, it needs to be having different characters from DCIS. Okay, so almost see, even if it is LCIS, ultimately it changed to invasive ductal carcinoma. Okay, so that's the reason that it's no longer considered to be what is it considered now?
Risk factor.
Yeah, it's a high risk factor. So right. So yeah, tell me something about, did we discuss last time about ITCs and all?
Yeah, ITC no.
No?
Not discussed.
Okay. Tell me something about micrometastasis, ITCs.
So ITCs are basically cluster of malignant cells less than 200 or size more less than 0.2 mm, and micro will be 0.2 to 2 mm, and more than 2 mm will be like as we define N1 or M1.
Okay.
So one type can be molecular as well, not seen elsewhere, but molecularly positive.
Okay. Fine. So any other imaging? MRA?
If suspicion of brain mets, or we want like high risk screening for high risk.
Tell me five indications for MRA.
So MRI is indicated in high risk patients, screening of high risk patients for CA breast and having familial mutations like BRCA.
High risk in the sense, what is the amount of relative risk beyond which you prefer doing MRA?
20%, I guess.
20%
is on
lifetime
20 to 30% based on the risk assessment models. So more than 20%.
20 or 25?
20.
20.
20.
And
20.
more than 15 is like relative indication, and less than 15 non-indicated.
Okay, fine. So other than that, okay, familial history,
Yes, ma'am. Other than
relative risk more than 20. Then
isolated axillary nodes with negative USG and mammography.
occult. Okay.
Yeah.
Then
And then, like, if any silicone implant or something was used, and we are suspecting scar, like we are suspecting
patient with implants. Okay.
Yes. Then after NACT for response assessments, mostly especially
No.
Recurrent.
lobular carcinoma.
There is one more.
Post BCS recurrence to differentiate scar and lesion.
Yeah,
And dense breast, very dense breast.
And
multifocal
carcinoma.
multicentric.
Dense breast and lobular carcinoma breast.
Multifocal multicentric.
No.
Focal. That can be.
No. That can be
Patient
I think last one is any discordance between two imagings.
correct.
Then
Discordance
can be
between two imaging. When you cannot characterize on the previous imaging. Okay. And these are the things. Okay, MRI.
And have a screening investigation in BRCA mutation patients.
Yeah, we discussed no familial high risk. Whatever
For
it
them,
is.
like for some locally advanced case, for response assessment, I read like MRI we can use.
If you have done an MRI before, then you compare it with MRI. Okay.
जैसे कि for
If you have
axillary
not done an MRI,
occult patient we are doing axillary N3 patient था पहले axilla में we sent for NACT, then response assessment also we will do with MRI only.
whatever investigation you have done before, compare it with the same. Okay, pre-NACT.
Okay.
So, tell me something about MRI. What are that curves called? And which curve is malignant? And why is it so?
Kinetic curves.
ABC curves.
What are the name? What is the name of that curves?
Kinetic curves.
No, kinetic.
Phase
Okay.
1,
What
phase
is
2,
the
phase
name?
3.
Plateau.
Plateau.
So they are called Kuhl's curves. KUHL. Okay.
Kuhl's curve.
Then what are the curves? What are type 1, type 2, type 3?
Type 1 benign, type 3 malignant, type 2 indeterminate.
So type 1, what happens?
Type 1 uniformly rise and
Type 1 will be persistent. Slow
plateau.
washout.
And malignant will be
type
plateau.
1 will be rapid rise and rapid fall. Okay, generally seen in benign lesions. Okay, so it is because of what is MRI based on? Differential movement of molecules, right? Protons.
Molecules. Yes.
So they, whatever benign the movement will be, they'll be move rapidly and they'll come to static phase. Okay, all of them. Okay, whereas type 2 will be rapid rise but plateaus. Okay, so that, as you told, they are indeterminate. Okay, so something between benign borderline types. Okay, type C is
Malignant.
rapid rise,
Rapid fall.
slow fall. Okay, so because they are malignant. Okay, so their rate of movement
Is slow.
differential movement of hello.
Yes, ma'am.
Differential
Yeah,
movement
you're not
will be
able to
slow.
Yes. So they will have rapid rise, but they'll not be able to move fastly to come down. Okay, that will be the malignant lesion, type C curves. Okay, and type 3 curves.
ADC also they will restricted diffusion in malignancy as compared to benign.
Yes.
This is opposite of DWI, diffusion weighted imaging.
What is ADC? Since you are related to it, I just asked.
So diffusion weighted.
What is ADC? What is full for?
Apparent diffusion
Coefficient.
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 Okay. Anything else other than this? MRI sequences.
T1 T2 पर breast में कैसे देखना है?
Diffusion T2.
What is it? It is same in breast, Samita.